So a little bit of show of Sheba Medical Center. It's the biggest center in Israel or in the Middle East. We have all types of departments. In general, Carbofix, we use it. I'm going to talk about oncology and why I'm using it, but we are using it in traumatology. Non-union cases started to get a lot of interest using this material, the Carbofix plating. And we have a very big department of hand surgery, and they are getting more and more interested in using this type of plates. But I'm going to talk about why I'm using it, what makes me use it. We started and we spoke about the advantages of the carbon and peak, the artifacts that they will measure, and I'm going to get about it a little bit more, and in radiation, because in orthopedic oncology it's very, very important. So all the bureaucracy of materials, can we use it or not? They showed you that it's already legal in all over the world, and this is the base of using it. In general, orthopedic oncology, what do we need in our operation? We need, in metastatic disease, we need to do the minimal operation and to get absolute stability, immediate weight bearing, and immediate, as immediate as possible movement. This is the concept of orthopedic oncology. Do as less as you can, but you have to achieve absolute stability and weight bearing immediately. Those patients don't have the time to heal, and we don't let them to heal for months, and after that, and just after that to start walking. In peak, we speak about the radiation. Oncologic patients they are complex patients. We need to combine different types of treatment, chemotherapy, radiation therapy, surgery, and need to combine it in a way that everything fits together. Nothing prevent other kind of treatment. If you're taking them to a bigger operation with complications, with high rate of complication, they can't get the chemotherapy and they die. So we have to take in consideration all of that together and to decide what comes first: surgery, radiation, chemotherapy, and so on. Type of radiation. I'm going to a little bit speak about it more about the radiation. There's several types of radiation: gamma radiation, proton radiation, carbon radiation. That at least in Germany you have carbon radiation, and in Germany and in Italy, it's something that we like to have it as well. And composite materials allowing all type of radiation to be, as much as we know now, better than when there is a metal implant inside the bone. In general, radiation. Radiation, we talk about the smart people, the radiation oncologists. It's all about physics. There is a lot of graph. I'm not going to speak directly about them. There is the backscattering, a thing that calls how much from the radiation that comes towards the bone goes back. Okay, this is backscattering. Attenuation is what passes over the bone, how it spreads around. There is different types of measuring, and it's very complicated to understand that. But we want that the bone will get as much as, not as much, exact amount of radiation that we want for it to get, not only the bone and soft tissue around. We want to know the precise amount. We don't want that the area that is not affected by the tumor will get too much radiation. This is all the idea around measuring radiation and building a program, a right program. Radiation for bone, it's bad. It can cause fracture in the long term. It can cause secondary malignancy. It can cause osteopenia, not only on the region that was radiated, but as a systemic effect. And it's all dependent on the doses. They don't really know how the bone reacts to radiation, especially if there is metal on that. There aren't a lot of works that manage to show us what happens to the bone, what happens to the surrounding when there is metal around it. They have some kind of calculation, and it's very vague. How much radiation should we give, how many times, and what happens around it. What they managed to show here with the carbon, comparing to the stainless steel, comparing to the titanium, is that there is a less backscattering and less attenuation. That means we can measure much closer the direct amount of radiation that we want to give to a certain area. This is all about those graphs. We can measure it, we can calculate it even when there is already a metal inside the bone. It's not always that we can send the patients to the radiologist, radiation oncologist, to make the measurements before the operation. All the metastatic tumors that are coming with fracture, we usually first treat them, and only after that they are going to radiation. To build a plan, when there is a metal inside, it's like working in the dark. They don't really know how much, they give much more than they need, and with this peak, at least those works show us that they can do better, less radiation for a focal place. The graph shows in green, it's the peak, the red and the blue, it's stainless steel and titanium. But I'm not going to go more about it because it's complicated and we leave it to the smart people, not the orthopedics. They showed me that this same type of thing in colors, radiation, how it scatters around after it hits the plate, and what is the backscattering, how it condenses around the plate. This is an objective fact that makes us, the orthopedic oncologists, prefer PEEK or carbon instead of the metal that we are used to. This shows that it's better, and it's very important in orthopedic oncology. So this is one reason why we are using it, because the radiation. I'm going to move over it. There is a part of, again, measuring. There is the Hansfield unit. How can we measure Hansfield unit? How the metal makes this measurement much more difficult and much more difficult. Again, the color shows different types of metal, stainless steel, carbon, and titanium, and show that we can measure the soft tissue Hansfield unit better. Again, making the radiation easier to plan. Again, this is the spine, metal, carbon, measuring the Hansfield unit. I'm going to pass over it, the Hansfield unit. So I'm going to show some cases and try to tell you about experience. So like that, you're all experienced surgeon. You do surgery for many years, and whether we want it or not, we are used to see things as we are used to. We used to see the nails, you used to see the plates, and when you're going to start using these nails and plates at the beginning, it will be uncomfortable feeling. This is what I had at the beginning, because you don't really see, you don't know what to pay attention. It feels strange, it feels different. Don't expect it to be the same as coming and nailing a fracture, a peritoneal fracture. It will be different at the beginning, but it passed very, very fast. After 2-3 cases, you're going to get very, very comfortable with what you're seeing, and then after some more cases, when you're going to see the nails, the metal nails, it will be strange to see the metal nails, because, and this is the subjective way why I prefer this type of carbon. The feeling is when you see it with a nail or without, it's like somebody takes a veil or something out of your eyes, and suddenly you can see things. And when you're getting used to it, you can't see it back because it bothers you. You can see the tumor, you can see the fracture, you can see the union. And when you're looking at other cases with nails, it bothers you in the eye because you can't see nothing. You can see, we are seeing it for years, but not as good as with the carbon. So visualization, this is a very important part why I chose to continue using it. This is the easy start, 78 years old woman with lung carcinoma, metastatic cancer. This is the small tumor, fracture. No. And this is the nail. What's important here in the nail? The first part is to see the edges. I'm going to show it in other cases. At the end, there is a small point, dart, that shows you where is the end of the nail. The same in the upper part. Humeral nail as well. You have to make sure that you are seeing it. Don't push it too deep because you can't really see. Again, something that we're doing very easily with metal nail. We know how deep we want to put it at the beginning. We have to take very good measure to see that we are not inserting too deep the nail. Another very important thing is rimming. We are doing rimming at least 2 sizes bigger than the nail. What we felt during our operation that the carbon doesn't like torsion. If you're trying to push the nail with, not to hit it, it's not a problem, but if you're trying to push it with different strength, rotate it, it hurts the nail, it hurts the cover. So we are trying to put it as easy as possible, a lot of rimming. For the screws, again, we have to do taping. For the upper screws, again, in the gamma nail, in the PFNA, usually we don't need to do any taping. It goes straight. Here we have to do the taping. Another problem with oncology is the stiffness of the bone. Some bone is very soft. Other bone is very hard. Very hard post-radiation bone that you have to drill it very hard to open the place, to open the canal. Sometimes we have to drill it. It's not enough to do it with the first drill. And you need to have some more patients in orthopedic oncology patients. Sometimes you need to have more patients to prepare the canal better, to prepare the taping better. Otherwise, it can cause a lot of problem. So this is a regular nail. Humerus fracture, again, breast fracture, breast CA, metastatic. The nail here, we can show, this is the tip. See that? It's a very common mistake in any nail to put it a little bit higher, too higher, a little bit out of the bone. So make sure that you see the nail. Sometimes you are open enough through the rotator cuff and you can see it by your eye. But this is an important point to notice. The distal part is here. Okay, here we used cement because there was a lot of bone lost, and it is great. You can see all the area very easily. Nothing bothers you. And again, radiation after that, very important. Less radiation, much more accurate. Multiple myeloma. Multiple myeloma, as in general, we are using long nails to do one operation. Even if the lesion is very proximal, we're going to do one operation that will cover all the bone. There is some conversation whether you have to do it or not. But this is still what we are doing. Again, here the point is a little bit too high. And why I put this part, look here. That wasn't planned, this part of the operation. I put it because the humerus gets very narrow, you all know that, but we didn't pay attention well enough to the distal part. Another bump, another one, and this is the fracture that we caused. Because the small to put attention to the length of the nail. Here's why I put the case here. As Professor Graber, Ranke, sorry, told you, it's not really difficult to move from what you are doing now to this type of nail, because everyone that does the gamma nail, everyone that does the phylus plate, it's very easy. It's the same. It's the same screws, same things. Everything it feels the same. But those small parts that you have to pay attention to. Another case, tibia, multiple myeloma. It looks like here she started to do some connection. It's post-radiation, but clinically the woman couldn't walk. She did a PET scan, showed that there is a lot of disease in spite of the treatment, systemic treatment and radiation. So we decided to put a nail inside. This is how it looks. A little bit after that, now she's walking. She's not very happy because she says that her leg is still crooked. Here you can see we chose not to fix the angle because it's a bigger operation with osteotomy, and the reason for the operation was just let her walk as much as she can. Giant cell tumor. She's 55, a little bit too old for that, but this is the MRI. So something that looks like giant cell tumor. Pathology shows giant cell tumor. The treatment for that is curettage with adjuvant cryosurgery or argon. And then there is a big debate, not debate, whether to put bone graft or cement, because what we are afraid of is recurrence. With recurrence, and if we're putting a plate, it's very difficult to see. Not impossible, but difficult. Here we used the plate here. It's a distal radius because they don't have yet the proximal tibia. So we use the distal radius from the other part with cement. You can see the lesion very well. Doesn't bother. You can do CT, MRI, whatever we want. It's much easier for us to see whether there is recurrence or not. This is classic for carbon. If I'm speaking too fast, you can stop and ask me. Low-grade chondrosarcoma, grade 1 chondrosarcoma. Low-grade tumor, difference between low-grade and enchondroma, it's not important, but it was with a lot of pain. So again, here it's curettage, cement, and the plate. I have a lateral? Yes. No, this is not a good lateral. But what you ask me about it, it's not difficult to feel and to see the proximal part, to see that you're in the middle. It's not harder than when you're using a regular plate. You can see it, of course you can feel it, and it's the same. This is how it looks in X-ray. This is how it looks in MRI. The screws already a little bit, no. The screws are a little bit in the way, but still you see it much better than any other plate that we are using. And for those type of patients, we do need MRI, we do need CT. In metastatic patients, we seldom need that. We don't really need to do MRI or CT. But with giant cell, low-grade tumor that we are using plate, it's very important. This is 2 years after that. He developed some kind of osteoporosis, didn't want to walk, but otherwise now he's well. He's tourist guide and he's walking, and I don't know if he's happy, but he's walking. Renal cell carcinoma, okay. In general, renal cell carcinoma, it's a little bit different type of metastatic disease. It doesn't react well to radiation. There is a lot of bleeding if you are opening it without angiography, embolization before that. I don't know if you are familiar with that or not. We are used to do embolization, and we don't leave it like that. We have to fill it. Another problem with metal problem. Another part with the metal nail is that when you are filling it with cement, you first put the nail and then you fill with cement. You don't always know how much cement you put. Does it cover everything? You can't see it really. Here, we saw that we have cement, not as much as we wanted to, but we can see it, and we can decide whether to put more or less. It makes it easier for us. Okay? So again, an advantage. And he went to radiation after that, and he's well. A little bit after that, he came with pain on his humerus, the same patient. At this part, he had some problem he had tumor on his trachea as well. So we did in regional anesthesis. Regional anesthesis, they were a little bit worried. They asked us not to open it and clean it. So we just nailed it. And as you can see, it's like every other nail, no problem. More cases. Anurysmal bone cyst. Anurysmal bone cyst, benign tumor, usually local active. We treat it because it's active. This woman, 42 years old, was very painful, with a lot of pain. We did a biopsy, we did an MRI. It looks benign, it was benign, and we curated it and used the plate for that. This is how the plate is used. And you can see by yourself that you can see better. And if you can see better, the reason said that we can treat better. Again, she is well. This is no, not her, but she's 3-4 years after that, and one of the first plate that we used of the carbon. Breast carcinoma fracture. Again, the nail. Nothing special here. Again, I showed it here to see how well you can still see the tumor. In breast carcinoma, usually we don't curate it. It's radiosensitive, so it's enough to get radiation for that. But we wouldn't see that with the nail inside, and they know this is the area that's supposed to get the highest part of radiation. This is the same woman. This is how it looks on CT. Almost, it's not that we don't have any interference there, any attenuation, but it's much, much, much less than we are regular to see with regular metal. We can see it here. I wanted to bring the whole movie, but I didn't know how to put it on the slides. But you can see that you can see better. And this is how it looks when you're doing 3D. Again, it doesn't bother. You can see here inside the line. But you can use the 3D and see it well. There was a lot of question. I didn't work those cases about removing plates. Again, in orthopedic oncology, we don't use a lot of plates because we are trying to cover the entire arm, the entire leg. We had some 3-4 cases that we used a type of plate. I don't remember even what type of plate was. For children with unicameral bone cyst around the hip joint, where you're going to create it, you fixate it, and after a year or two, you take it out. It was, first of all, it healed very nicely. I know it's because of the carbon or because of the biology. And when we took it out, it was very easy, like exactly as it was in the movie. Don't expect it to be a miracle, like never to have any problems or breakage or whatever. It's a device. The more we're going to use it, probably we're going to find some problems. But for now, it gives us a very good visualization. It's very easy to use, to move from what we're used to the CarboFix system. And now, another very big advantage for us, at least, it's a small company. We have a direct line to the company. If we need something, we simply call them, and they are building it. We had now in the hand surgery that you mentioned, they needed something. What they needed? They need something bigger than what they have.
Because Ivan just asked me if we can make some sleeve.
Okay, sleeves, bigger sleeve.
I didn't say no. I didn't say no.
So maybe I make it primal. We needed some bigger sleeves. It was very fast. We got an excellent response. It's make it easier. We did that. We want to change something because it's not such a big company, and they are listening. They are very good listeners. It's easier for us to work with. All about the part of bone healing better. I don't know if we are as orthopedic, we are buying it. We are usually we are not buying this kind of things. I don't know if the healing is better because we can see it, or it's actually better. This is only time will show. At least one of the slides, there was too much healing there. Someone, I don't know if they show the cases. If you remember a case of the proximal femur with a lot of bone build, I guess he had some head trauma that it looks so good. But again, easy to visualize, good with radiation, very good response to get from the company to change things, to build some things. And the removal looks very easy as well. So this is why I'm using it.